Good morning, everyone. Good afternoon or good evening for those who are joining us from different time zones. So my name is Khasiani. I'm the Medical Education Manager at WFH, and it's a great pleasure to welcome you to today's webinar, highlights from the third edition of the Laboratory Manual 2025 in collaboration with Group CLATH. So thank you very much for taking the time to join us. We are very excited to have an amazing professional with us today who will share their knowledge and experience on this important topic. So let's start it. So let me introduce you for Jason Martin. He is the head of humanitarian aid and medical training. Jason.
Thank you, Siane. On behalf of the WFH Humanitarian Aid and Medical Training Department, and of course our director, Dr. Asada Far, we warmly welcome you to everyone to today's webinar. As you know, this year the WFH released the third edition of the lab manual, and this is thanks to the dedicated efforts of the laboratory committee. The manual has been updated to reflect the significant advances in technology and technique that we've developed over the past decade. I'm sure you all know we understand the critical role accurate diagnosis plays in the treatment of bleeding disorders. So we hope that the manual continues to be an important resource in your work and within the bleeding disorders community. Just to let you know, to broaden its access, we've also rolled out the manual in multiple languages, including Spanish, in both print and online formats. If you want, just reach out to our medical education manager, Siane, for copies of these. Today's webinar is part of this initiative, and it was the idea of our current laboratory chair. And I'd like to introduce the panelists today. Our chair, Silmara Montalvao from the Universidade de Campinas in Brazil. And we have also with us the other contributors to the manual who will share key highlights with you today. We're also joined by Kieron Hickey from Sheffield Teaching Hospitals in the United Kingdom, Anastasia Khasiani from Atlanta, Georgia, the United States, and last but not the least, Dr. Steve Kitchen, former lab chair and current director of the WFH International External Quality Assessment Scheme, or IEQAS program. We sincerely thank all of them for generously sharing their expertise and experience with us. We hope that you will enjoy the webinar, both from an educational and from an engagement perspective. And with that, I'll hand it back to Siane to guide us through the agenda and to begin the webinar proper. Siane?
Okay, so here is our agenda. And the panelists. So the first speaker would be Dr. Kieron Hickey, sample integrity and preanalytical variables. The second one, Dr. Anastasia, initial evaluation of hemostasis. And Dr. Steve, the last one, troubleshooting issues with coagulation laboratory tests. Each speakers have 15 minutes. Question and answers will be in the end, and we encourage you to write your question in the chat box, and we are going to read in the end of this webinar. For the disclaimer, the WFH does not promote any particular pharmaceutical product or any mention of any commercial brand in this presentation is strictly for education purpose. So Dr. Kieron, please, it's your turn.
Thank you. Good afternoon from Sheffield in the UK. I'd like to thank everyone for attending this webinar. I was fortunate enough to participate in the latest iteration of the WFH lab manual, and I'm talking today about sample integrity and preanalytical variables. So all of us as lab scientists are trying to achieve the same thing, to generate high quality, reproducible lab results. And the first step in that process is strong control of the preanalytical conditions. And we're doing all this to ensure that any results we generate best reflect the patient conditions. Next slide, please. So the preanalytical phase is the main source of inaccurate lab results. It's estimated that between 1/3 and 3/4 of errors are associated with this phase. And it's particularly prevalent in coagulation because we're dealing with enzymatic reactions, particularly sensitive to preanalytical conditions. And it can estimate it to affect up to 5% of laboratory samples. And the real risk we have is testing unsuitable samples is dangerous because you risk the release of results which are unsafe for clinical decision making. Next slide, please. So when we start off with venipuncture, with blood collection, blood should be taken into an evacuated blood collection system. The recommendations are to use a 19 to 21 gauge needle in adults, a 22 to 23 gauge in children. And it's important that a single tube type is used in your institution because each tube types are not the same and they can actually give different laboratory results for the same parameter. So a single tube type should be selected for your institution, and that tube type should be used to generate the reference intervals used for testing. And even within the tube type, if the manufacturer offers a glass and a plastic tube, these also aren't interchangeable. So you really should select a tube type that is of one form, let's say plastic, from one manufacturer. And that's the first step in the process of interpreting your lab results successfully. Next slide, please. And with regard to tube types, we're talking about coagulation. So blood should be taken into a 0.105 to 0.109 molar trisodium citrate tube. Collection draw is important because we want to avoid EDTA and heparin cross-contamination. So we all should be trying to follow the WHO blood drawing guidelines. The reference is indicated at the bottom of the screen. And venous blood requires immediate anticoagulation with a minimum 80% fill and gentle inversion after venipuncture. But what we want to do is mix the trisodium citrate with the whole blood sample so the citrate can chelate or bind to the calcium to keep the sample in stasis before testing. One of the issues we have is with high hematocrits. When the patient's hematocrit is greater than 55%, this can require an adjusted citrate bottle. I think if you press twice, an image will appear. I think click, I should see a calculation appear on the screen. If not, we can move on to the next slide. So in the WFH manual, we have incorporated a calculation which is pretty standard and universally applied across the world, and as a way of adjusting the citrate bottle. If you click again, please. So we can see here that this patient has hematocrit of 70%. So we've had to adjust the citrate bottle to 0.25 mils of citrate to compensate for the higher packed cell volume in the tube. Next slide. And this is an image I borrowed from Dr. Kitchen, and it's an indication of what you can see with a high hematocrit. If you look to the right-hand side of the screen, you see a high hematocrit packed cell volume with very limited citrate. So we're not maintaining a 9:1 blood to anticoagulant ratio. And you can see on the far left, this is the more typical sample you'll see in most patients with a lower packed cell volume. Go to the next slide. And we know with high hematocrit and also underfilled samples, you can get inaccurate results. So we can see on this slide here, we have a sample on the right, correctly filled, and an underfilled sample on the left. And in the underfilled sample, when tested, it generated an INR of 9.8, an APTT of 84.2. If you click again, please. But in a correctly filled sample, the INR was 3.7, the APTT was 45, just indicating the unreliability of samples if you're not achieving the minimum 80% fill. And you can often see a similar pattern of results with high hematocrit samples. So vigilance, either through automated but visual inspection is just as good, depending on the analytical capacity you have in your institution to identify hematocrits, high hematocrit samples, and samples which are underfilled. Next slide, please. When you come to processing samples, for single sponge samples, for routine coagulation investigations, for factor assays, a speed of greater than 1700 G for 10 minutes is acceptable. There are some investigations, like DRVVTs for lupus anticoagulant detection, where you need to remove more of the platelet counts or more of the platelets from the sample for reduced platelet count. Here you double spin the sample. You'd remove the plasma from the sample indicated above from the primary vacutainer tube. You would then take it into a secondary tube, the plasma, spin again, take off the supernatant, and that supernatant would have a platelet count of less than 10 times 10 to 9 to make sure the phospholipids and platelets don't interfere with phospholipid-dependent tests like the DRVVT. If your institution is doing platelet-rich plasma testing for platelet function investigations, samples should be processed at 770 G for 15 minutes or 250 G for 10 minutes. And when you are centrifuging samples, avoid cold centrifugation because that can lead to platelet factor 4 activation, which has been shown to interfere with things like factor 8 measurement, lupus anticoagulant detection, and unfractionated heparin monitoring. Next slide, please. We also have a concern with interfering substances. So during venipuncture, a patient may have a difficult or traumatic phlebotomy. You get shear stresses acting on the cells, which can lead to hemolysis. We know locally and in the published literature, hemolysis can have significant effects on coagulation results. And in particular, they can change the results of things like APTT, either causing false normalization, where the true result in the patient is abnormal, but due to the hemolysis effect, you get false normalization, but also a false prolongation, where in the hemolyzed sample, you're getting a prolonged APTT, which may lead to additional investigations, where in fact, in a non-hemolyzed sample, the patient has normal clotting profile. It's important to remember that some patients have intravascular hemolysis, and it may necessitate testing samples which are hemolyzed because you are reflecting the situation inside the patient. Iterus and jaundice, routine assays are usually unaffected by this. And with lipemic samples, which you can sometimes see, this can be overcome by ultracentrifugation. Next slide, please. This is just indicating the type and degree of hemolysis you may see in a sample. Again, in the control, you have the standard sample you'd be content to test, but then you have increasing degrees of hemolysis, 1 gram per litre, 6 gram per litre, up to 15 grams per litre, which in a normal setting, you would try to reject the hemolyzed samples because you want to reflect the hemostatic system in the patient. And as mentioned, you can see changes that are unwanted. But it's also important to remember if the patient has sickle cell anemia, autoimmune hemolytic anemia, or TTP, there may be occasions where you do need to test this sample. So a pragmatic approach is required. Next slide, please. Now, when it comes to storage, these are enzymatic reactions. Sample testing is time sensitive. The general recommendation from CLSI is that all samples should be tested within 4 hours of venipuncture. This is for samples stored at room temperature. It's clear if you're in a country where you have higher temperatures, a higher room temperature can affect the stability window. So if you are going to test samples outside this 4-hour window of stability, you would need local data to support that approach. And if you are not going to be processing the sample straight away, plasma can be stored at -24 for 3 months. And if samples are required to be held for longer term storage, greater than 6 months, they can be stored at -70 degrees C. Next slide, please. If you have frozen samples should be forwarded in a water bath at 37 degrees C. We forward these samples locally for 3 to 5 minutes. We do gentle inversion post-forwarding to make sure we've homogenized the sample. And once we've used this sample, which has been forwarded once, we discard it and no further investigations can be performed because, again, results on a sample that's been frozen forward twice can be unreliable. Next slide, please. So in conclusion to the short presentation, high quality samples are essential for effective laboratory diagnosis. Vigilance of the preanalytical conditions help increase us as lab scientists in the confidence of the results we're issuing. So rigorous adherence to local sample acceptance policy should be applied. And in each institution you work in, you should consider the environment you're working in and set on a policy that works successfully locally. And it may well involve interaction with people that may be outside your department, like phlebotomy, for example. But what it does overall, this interaction, is help improve the quality of the blood samples you receive, because you can have better quality phlebotomy, less hemolyzed samples, less underfilled samples, and the people drawing the samples have a better understanding why we have strong adherence to preanalytical conditions to help drive better quality lab results as our primary goal. And vigilance is also required in the laboratory, correct centrifugation speeds, reviewing sample stability windows, visual inspection of samples for hemolysis, underfilling, high hematocrit, and then storage of the samples correctly, either testing within the right window or storing a sample at -24 or lower for longest term storage. I'd like to thank you for your attention, and I'm happy to take any questions at the end of the session.
Thank you, Dr. Kieron. So next speaker, Dr. Anastasia. Please, it's your turn.
Thank you very much for this opportunity to make this presentation. Next slide, please. So the scope of my discussion is going to cover the definition of hemostasis, the clinical and laboratory evaluation, and then a summary of that. Next slide. So normal hemostasis functions efficiently in an environment where there is an equilibrium of procoagulants and anticoagulants in the presence of a normal vascular system. So whenever any of these components are affected in their functional capability, then it affects it comes about as a disorder to do with either thrombosis or a bleeding disorder. Next slide, please. So hemostasis can just be defined as a physiological response by the body to stop bleeding at a site of injury. So there are three main phases that enable hemostasis. That is primary hemostasis, secondary hemostasis, and then fibrinolysis. In primary hemostasis, then you find that there is the initial vasoconstriction of the blood vessel to slow down blood flow onto the site of injury. And then there's adhesion of platelets to the site of injury by assistance from the von Willebrand's factor that has been released from the endothelial cells. So the von Willebrand's factor attaches onto the GP1B receptor on the platelets. This leads to the activation of the platelets and make them adhere to each other. As the activation takes place, then there's release of certain substances from the platelets that attract more adhesion of platelets to the site. So the substances that are released are such as von Willebrand's factor and factor V from the alpha granules of the platelets that enable aggregation of platelets at the site of injury. So the long-term result of this process is the formation of a platelet plug at the site of injury. In the secondary hemostasis, there is the activation of the coagulation pathways by the exposed collagen at the site of injury and the production of tissue factor. This triggers the activation of the coagulation cascades, and the end product will be the stable fibrin clot formation at the site of injury. This enhances the sealing of the site of injury to stop blood flow from the injured area. And then fibrinolysis will take place to help in the clot resolution. And once the clot has resolved, there's tissue repair and cell regeneration so that function can be restored. Next slide. So cell-based coagulation is the actual in vivo process that takes place during hemostasis. It occurs in three different levels of phases that overlap each other. So during initiation, there is the production of tissue factor from the injured cell membrane that activates factor 7 in circulation. So the activated factor 7 forms a complex with tissue factor and moves into close proximity with the activated platelets. And then there's further activation of factor 7 in circulation that will continue as the factor 7 is activated. This leads to the thrombin generation through the coagulation extrinsic pathway activation. And the next phase is the amplification, where platelets attach onto the damaged cell membrane. This is through the assistance of the von Willebrand factor. So this enables them to be activated and become sticky and attach onto each other. As they become activated, they produce substances from within them, the alpha granules that contain factor 5 and von Willebrand's factor. And this enables the activation of coagulation activity around the site of injury. This coagulation activity then triggers the production of thrombin at the site of injury. Next slide. So the final phase is the tenase complex and prothrombinase complex attaching onto the platelet surface to enhance coagulation activity at the site of injury. So as the coagulation activation goes on, there's the conversion of, there's massive thrombin production, and this thrombin production helps in the conversion of fibrinogen to fibrin, and this will enable the stable fibrin clot formation at the site of injury. So natural anticoagulants are there to ensure that the clot forming process does not occur outside the area of injury. Next slide, please. So the coagulation pathways enable us to understand and interpret the results that we get in the laboratory. They may not reflect exactly as it is in the in vivo, but when you're doing your laboratory tests, it's good to understand which coagulation factors are involved in which coagulation test that you're doing, because that enables you to understand, okay, where to start assessing your problems from. Next slide, please. So before you do your laboratory evaluation, the clinical evaluation is important because you need to collect the family history data from the patient, the medical history, and a full examination of the patient. If you suspect that the patient may have a bleeding disorder, then a bleeding assessment tool can be used to collect all the history regarding bleeding on that patient. If it's suspected to have, if the patient is suspected to have a thrombotic disorder, then you use a thrombotic assessment tool to find any details of thrombosis, either to do with the patient or in relation to the family of the patient. Next slide, please. So in your laboratory evaluation, you begin with the screening tests. This will help you to find out where the abnormality is. So just to give some context, all the tests that I've included in my outline are mainly in regards to if you are presented with a patient who may have a bleeding disorder. So there are other times when the patient may have other forms of coagulation disorders. So in this case, we'll start with the PT, APTT, thrombin time, or fibrinogen, a CBC, and then if you suspect that the patient may have von Willebrand's disease, it will be good to include a platelet function analysis or a bleeding time if you do not have access to a platelet function analyzer. So once you've obtained your initial results, then the next thing you do is to do a mixing test on the results of the test that has given you an abnormality. So here, assuming that probably PT was abnormal and APTT and TT are okay, then you do a 1-to-1 mix. So you take equal portion of patient plasma and normal pool plasma, do the mix, and then repeat the APTT on that sample. So this will help you to identify whether these are an inhibitor or an antibody or a factor deficiency in that plasma of the patient. Same applies if the abnormality was detected in your initial APTT result. If it is abnormal, then you can do the mix and then identify whether there is an antibody or a factor deficiency. And then I need to mention that if it's already mentioned in the clinical notes that the patient is on an anticoagulant, then you do not need to do a mixing on that test result, because for a patient on anticoagulant, you do not need to do mixing test on it. And then some important information to note is that you are supposed to collect enough sample at the initial point of meeting the patient so that you do not go back to collecting more samples, because sometimes you're supposed to do further testing for that particular patient, and therefore collecting enough sample at the initial point will be good. And stress can affect some of the coagulation parameters, and therefore ensure that the patient is calm when you're collecting the blood sample. Next slide, please. So in your secondary testing, the tests that you do in your secondary testing are determined by the abnormality that you identified in your screening tests. So starting with the coagulation tests, you can do specific factor assays after identifying that there's a factor deficiency after doing your mixing test. So this can apply for both intrinsic pathway coagulation factors or the extrinsic pathway coagulation factors. And then if the mixing test identified that there was presence of an antibody, then you need to do either an inhibitor assay if the history of the patient suggests that this could be a patient with hemophilia and may be developing an antibody. So you do the inhibitor assays to quantify the concentration of the antibody present. And then if the antibody present could be an antibody against phospholipids, then DRVVT confirm and DRVVT screen can be done and the ratio confirmed. And then once you have your report, that should be repeated after 8 to 12 weeks, just to ensure that this was not a transient type of an antibody. And then when it comes to platelet disorders, the initial CBC can give you a quantitative view of whether there is an abnormality with the platelets quantitatively or not. So you may note whether there is normal platelet count or thrombocytosis or thrombocytopenia. In addition to that, you can look at the blood film to look at the morphology of the platelets. This is able to tell you whether the platelets are functioning normally or not, especially when you find giant platelets in the blood film. In case you have platelet aggregation available to you, then this is a tool that can be utilized to study the platelet function to determine whether they are acting normally or not. So the platelets are exposed to different concentrations of agonists, and their pattern of response is recorded. So once this pattern of response is noted, then the abnormality can be detected from there, and the platelet disorder the platelet disorder can be detected there. So the von Willebrand's, if the patient may have von Willebrand's disease, then you start with von Willebrand's factor antigen, von Willebrand's factor ristosetting activity, and then factor 8 assay. Sorry, it's missing there. And then, so once you've done your baseline for von Willebrand's disease, you have to have your reference values for each, and then also do ratio calculations. And then using those two parameters, you can be able to detect whether it's a type 1, a type 2, or type 3. And once you've classified whether it's a type 1, type 2, or type 3, then you can use the different tests available to you to detect the subtype. So there are different methods that you can use to detect which subtype the patient may have in, which type 2 subtype the patient may have. So there is ristosetting-induced platelet agglutination, multimer analysis, collagen binding assays, and factor 8 binding assays. So these are the tests that can help you with detecting where the abnormality is in your type 2 patient. So genetic testing provides better molecular understanding of the conditions, and therefore a personalized approach in treatment. And therefore, if it is available, it is good for you to utilize it. And then again, I must mention that all these coagulation tests that I've talked about are well elaborated in the laboratory manual. So it will be good to consult that so that you can have a better view and understanding of all the tests. Next slide. So this is just an outline that I made to help understand how you move from the screening test and on to detect where the problem is, and then finally do your secondary test that will enable you to come up with a conclusive answer to the question, to the problem the patient may have. So it's mainly focusing on bleeding disorders, but there are many other coagulation disorders that can be detected with different kind of flow plans. Next slide, please. So in summary, when you're assessing a patient with a coagulation disorder, getting a clear patient history is important. And then a systematic approach in test selection is key so that you do not, run tests that are not necessary for that particular patient. And then a comprehensive care team consultation is key and it's recommended. And then if results do not make sense, because there are many times when you get results and they do not make sense, always review your QC to make sure that all your standard operating procedures are working okay. And then if need be, then request for a fresh sample so that you ensure that you give the correct results for that particular patient. Thank you very much.
So thank you, Dr. Anastasia. Now it's Dr. Steve. Welcome.
Thank you very much. And can I begin by saying it's fantastic to see so many colleagues signing up to participate in the webinar. I think it should give good confidence to the organizers that you did a great job in putting this program together. It's fantastic. Okay, so in this next presentation, I'm going to discuss some issues in relation to troubleshooting issues in coagulation laboratory tests. So I think we should remind ourselves that we need in the lab a quality management system, a quality assurance program, let's say, and that we have two components to this, both of which, in my opinion, are compulsory to operate in the lab. Internal quality control, IQC, and we need to do this to help look at the precision and consistency of our results for reporting. So we can use this to say that using the same reagents and methods today, we should be getting more or less the same result as we did yesterday and the day before and so on. So it tells us about the reproducibility. This we should be doing regularly and frequently. And there are some comments on that in the WFH laboratory manual. So we need IQC. But in addition to that, we need more information, because IQC cannot really tell us everything about, are we getting accurate results? Are we getting results that are the same as those obtained in other centers? And this, I think, we should get from external quality assessment, from proficiency testing. This is retrospective analysis. It compares results between laboratories. It can be used to compare results between methods. So there's all sorts of information we can gain from this. And I'm going to show you some examples, two examples, I think, from my own laboratory, one in each category, where we identified issues that needed addressing. So next slide, please. So the next couple of slides will illustrate an issue related to internal quality control. So this is, again, a real example from my lab. We were performing some manual prothrombin times. And in my opinion, perfectly acceptable to use the manual technique. I prefer an automated system if it's available. If it's not, perfectly acceptable to use the manual. We are, I think, fortunate in our area that the accuracy and precision of manual testing is adequate for diagnosis and monitoring patients. We were doing some manual testing. We used a QC material where the target for the particular reagent was 34 to 40 seconds. The result we obtained on this occasion, 45, clearly outside the target. My colleague checked the records, the thromboplastin reagent stored correctly, handled correctly, reconstituted correctly. We looked at the water bath temperature. The records confirmed it was 37 at the daily check in the morning. This is recorded, and that it was continuing to read 37. So a little bit puzzled. What could be the cause? Next slide, please. So I think we might, there we go. Yeah, thank you. So you already will get a clue as to what had occurred here. I'm saying first that the thermometers in use at this time in our center were checked every 2 years against an independently calibrated thermometer. I think it's important to do this, and that's also a recommendation. It's covered in the lab manual. Next slide, please. So the thermometer in the water bath, when the test was performed, did indeed read 37. However, when we checked that against other thermometers, and the first one we used was my finger, I dipped my finger in the water bath, and I said to my colleague, I think this is not 37. We fetched other thermometers. The others all read 42 degrees. The temperature was off, the water bath was too hot, and this caused this false prolongation of PT by 25%. So we have to check all aspects of the testing we're doing, and we have to keep an open mind. And here was a situation where, despite a previously acceptable process, here's a problem where it failed. And this can happen in coagulation laboratories. Next slide, please. So what do we do? What do we recommend? And again, this is discussed in the WFH laboratory manual. I think the key, it's obvious, it's self-evident, but I wanted to remind ourselves, if we've got an IQC out of range, we should suspend new patient testing and suspend reporting of any patient results which have been obtained since the last QC result was within limit. There could be some merit in retesting the QC. This would confirm whether or no the previous out of range result was an analytical error. We often jump straight to the next bullet to replace the QC material and retest. And often this will be solution. Often the QC material itself has deteriorated, it's moved outside its period of stability, and this will solve the problem. And of course, if it's the QC material, this will not impact patient results. If we do the retest, it's still out, then we need to replace reagents and retest. And this will usually solve the problem in our experience. If it's still out, then we have to look to a backup method. Next slide, please. So we should remind ourselves that we can have issues with QC material. So this slide is, again, it's more or less a real example of clotting times, at least from my own laboratory. Each of the arrows are beginning testing on a new vial of IQC sample. And you can see in between the arrows a gradual increase in clotting time. The APTT is going up, going up, going up over time. And in fact, this was a consequence of an unstable IQC material. We needed to discard this material and replace. Next slide, please. Here's a different example. Again, a Levy-Jennings plot. Again, APTT. A scatter of points in the first part of the graph. And then where the up vertical arrow, we start to see results moving up and outside in a general trend. So this kind of trend to higher results, this indicates a gradual change in one of the components. It could still be the QC material. It could be one of the reagents. It could be in the analyzer, for example, the light source in the analyzer. These problems are infrequent these days because reagents and analyzers are particularly well manufactured, but nevertheless can occur. Next slide, please. And it's one of the reasons, I think, why it's convenient and recommended to have two levels of QC, particularly, excuse me, particularly for screening tests where I think it's relatively easy to do so. And this slide shows an example, two levels of PT control, two levels of APTT. And you can see the various patterns. If PT and APTT are out of range on QC1, it's QC1 material. If they're both out of range on QC2, it's out of range QC material. Both PTs out, look to the PT reagent, and so on. So you can draw some conclusions about where to begin investigations. And this is, I think, much easier with two different levels. So that's the reason for a recommendation to do two levels. Next slide, please. But I think we should also remind ourselves that we can obtain really good information from quality assurance programs, from proficiency testing. And you'll know that there is a program available through IEQAS, from WFH, the International EQA program. And of course, there are a number of other national and international programs. So this slide shows some data from one of the EQA surveys. Actually, this particular example came from a UK NEQAS survey. And what we noticed here was that labs using one particular source of factor VIII deficient plasma in their factor VIII assay, one particular center reagent source was associated with different results. If you look at source C, A, B, C, D, E, and F are different commercial sources. Those using commercial company C, only 7 centers, but their results for factor VIII were about twice as high as all the others, suggesting a problem with the reagent. And when we investigated that in more detail, it became clear that particular manufacturer was providing a deficient plasma that was indeed fully deficient in factor VIII, less than 1 IU per deciliter. Good, fantastic. But it was also very deficient in factor V, not completely, but was only a small amount of factor V in the deficient plasma. So it was creating a non-specific assay, and that was the reason for this difference. So we can use this kind of data, I think, to help focus investigation. Next slide, please. But one of the two areas, I'll come to the second in a moment, one of the two areas that we noticed in our IEQAS and NEQAS programs, one of the two areas most frequently associated with issues in coagulation tests is the design of a factor VIII or factor IX assay. And the recommendations from WFH and others are, please do 3 dilutions of the test plasma. 3 dilutions, 3 different numbers. So what do we do with that information? What should we expect? Well, we've got a couple of options on how we should assess, are those 3 dilutions giving the same answer, more or less, close enough? One way is to calculate a CV of the 3 numbers. And if we do this, we should be having a CV of less than 15% for any sample where the factor level is at least 25 IU per deciliter. If the factor level is a little bit lower, we should expect to see a slightly higher CV, but should still be less than 25%. So a bigger CV, be suspicious. Think about troubleshooting. Some analyzers give us slope ratio calculations, and there are different approaches to this, but you can see on the slide the kind of ranges that should be considered acceptable, probably 0.85 to 1.15. Outside of this, we've not got parallelism. Some differences are occurring between the results in the three dilutions. We should troubleshoot. Next slide, please. And here's a specific example, a sample of assayed for factor 8, 3 different dilutions. And on the right in the graph, you can see a straight line relationship between the 3 clotting times of the 3 dilutions. But when they are converted into factor 8 activity, the estimated activity is different between the 3 dilutions. 9%, 15%, 26%. Very different. Non-parallel. Here we've got some interfering substance. Next slide, please. And the same plasma, when analyzed at higher dilution, increasing activity estimates for the 3 additional dilutions, 42, 105, 175. So this is a patient with a lupus anticoagulant. The lupus anticoagulant is interfering, and that impact of that interference is greater at the lower dilutions than at the higher. So we're approaching closer and closer to the real concentration at the higher dilution. This is the reason why it's really important to test 3 test sample dilutions. Next slide, please. And before we come to this slide in calibration, I can tell you that this problem with testing 3 dilutions, this has been really quite common to see this as the cause of errors in our IEQUAS participant group. Some labs which have been unable to test 3 dilutions, but when they've had highly variable results, but on introducing use of 3 dilutions, have seen a good improvement in their local results. The second most common cause of issues in our IEQUAS program amongst participants relates to calibration. So on the slide, we can see an example of some factor 9 assay results, local results consistently higher than those obtained in other centers. This is a typical clue that calibration may be the issue. Next slide, please. And so to help troubleshoot this and investigate this, for a lab who is using reagents that have been shown to give good results in many other centers, and that's often the case, we are able to provide some material as a tool to investigate possible calibration issues. We purchase SSC plasma from ISJH SSC. We hold a stock. We don't make a charge for this, but we are permitted to provide up to 3 vials to an individual center. We have to feed back to the standing committee on our use of this. Next slide, please. And here's an example. So the solid graph on the left shows the local result in the white columns for 3 surveys compared to the target, the median in other centers in yellow. And the local results, 3 surveys on the trot, more than approximately 40% too high. We sent the SSC plasma and went through with the lab. Try this, look at the calibration, let's see if that is the issue. They were able to identify a new calibration was potentially resolving the problem. They put a different calibration and process in place. And in the following survey, their local result was 10 IU per deciliter and the target was 12. Problem solved. So this is something to keep in mind. It is available. Next slide, please. And this is something which a number of laboratories have benefited from in recent years. This slide shows the last 3 years of countries where we've offered SSC plasma standard as an independent material. And these are the countries where laboratories have taken up this offer and have been able to improve their subsequent results as a consequence. So these issues occur everywhere. Next slide, please. So what do we do about patient results? If we identify through external quality assessment that our results are reading high, reading low, are out, We have to remind ourselves that during that period, we will have been testing in all likelihood patients. So we should review the relevant patient results during that time period that EQA was out of range. And the 4 bullet points in blue, this is an example from my own lab a number of years ago. We used a previous VWF antigen method, but we noticed in EQA our results were reading low. We went to patient results that had been analysed during the period of the problem identified through IEQUAS, and we paid particular attention to those patients whose results had been between 30 and 60 IU per deciliters, so around the critical areas for diagnosis, let's say. And I'm pleased to report that no normal subjects had been misdiagnosed as von Willebrand's disease, and no cases of von Willebrand's disease were misclassified between type 1 and type 2. That might not have been the case. If the problem had been large enough, and if we'd got any misdiagnosis, we should have recalled those patients and done new investigations. So we should always remember that out of range EQA can have a direct impact on patient. Next slide, please. And many of the issues that we've discussed, certainly the troubleshooting section I've just described, is covered in the revised edition of the WFH laboratory manual. It's available for free through the WFH website. And I want to particularly pay tribute to Silmara Montalveo, our chair today, because she did all the hard miles in bringing this 3rd edition through to completion. Thank you for your attention.
Thank you very much, Dr. Steve. Wonderful speak. So now Silmara will be the moderator about the questions, and she will speak in Spanish, and we will have the translation into English right now.
Gracias a todos los ponentes por sus valiosas presentaciones. Creo que va a ser algo muy importante para discutirmos acá las dudas que tenemos en cuanto al laboratorio. Gracias por compartir sus experiencias con nosotros. No sé si tenemos preguntas ahí de los participantes, mas me gustaría empezar una pregunta para Kieron. Sobre la parte de congelación y almacenamiento de las muestras. Me gustaría entender si menos 24% grados es suficiente para el congelamiento de las muestras también, no solamente para almacenamiento, porque hay muchos laboratorios que usan solamente menos 80 grados. Entonces, me gustaría que hablase un poco sobre esa parte de congelamiento y almacenamiento de las muestras.
Yes, thank you very much. You find that all of the guidance documents will have a 2-tiered approach, storage at around -24 with a stability window of 12 weeks, to acknowledge that not all laboratories have access to -70, -80 freezers. However, if your primary storage freezer is at -80, then samples are fine to immediately go into -80 storage for long-term storage of the sample prior to testing. Guidelines recommend that the sample storage at -80 is fine for 6 months. But you would probably be okay for 12 months of storage. Having said that, we have local data that supports even longer term storage, but you'd definitely be fine for storing samples either immediately at -80 for 12 months, or if you don't have access to that facility, storing samples at -24 for 3 months and testing the sample within that time window.
¿Entiendes que menos 24 es suficiente para los 3 primeros meses? ¿O que tenemos que ir a menos 80 ao invés de menos 24?
We prefer -80 as our primary storage condition, but that's predicated on our ability to access -80 storage. So that's our preference. If you're in an institution where you only have access to -20, -24 storage, then that's also acceptable. However, the storage window is shorter of only 12 weeks.
Sí. Y gracias, Kieron, porque hay mucha gente que tiene dudas sobre cómo hacer el congelamiento de las muestras. Gracias por su explicación. No sé si tenemos más preguntas. Acá no estoy viendo preguntas aún. Entonces yo voy a preguntar a Anastasia sobre las pruebas de las mezclas para TTPA. Me gostaria de saber se você usa um cálculo específico para evaluar as mesclas de TTPA, ou se usa solamente o tempo em segundos, e se isso é algo importante para nós outros que estamos aí em laboratório, se podemos utilizar muitos cálculos, ou se temos que mirar solamente o tempo, se está mais do que o rango que entendemos que é normal. Como hacemos a avaliação das mesclas de TTPA?
Okay, so when you're looking at your EPTT results before you do your mixing, first of all, you have to compare your result to the normal ranges that have been established locally. Once you've established that your EPTT result is abnormal and you require to do a mixing test, there is a percentage correction calculation that you can use. So this formula is available in the laboratory manual, but it just helps you to find out, is there a 50% correction or not? So in instances where there's a more than 50% correction, then you suspect there could be a deficiency of a factor, of a coagulation factor. And in instances where there's less correction, then you identify that there's an antibody. And then the composition of the normal pool plasma that you use for your mixing test should, there are many factors that affect it, and therefore you should make sure that it has a high concentration of all the coagulation factors necessary to determine whether there's a correction or not. And then if you're preparing your normal pool locally, there is a guidance in the laboratory manual, but sample collection should follow the standard operating procedures. And then there are certain medications that patients could be on. So if you're collecting these samples so that you can pull them together, it is good to find out if the samples that you're collecting, do they have any medication or some conditions that the patient may have that can interfere with the coagulation, with the normal coagulation mechanism function. So this, ruling out all this will help you have a proper normal pool plasma that you can mix with the patient plasma so that you can identify whether there is any deficiency or not. I don't know whether I answered the question.
Okay,
No,
thank
creo
you.
que sí. Gracias, Anastasia. Entonces, si tenemos duda cómo hacer la interpretación de las mezclas, podemos entonces accesar el manual de laboratorio. Sí, gracias por su explicación. También solamente gostaria de que Steve hablase un poquito, porque estamos cerrando, del coeficiente de variación, Steve, ¿cuál es el máximo permitido para fatores de coagulación? Cuando hablamos de controle de calidad interno, ¿cuál es lo máximo que usa en su laboratorio para decir si está bueno el controle interno o no? Para fatores de coagulación, principalmente para factor 8, que es algo importante en nuestros laboratorios.
Yeah, I think it's a good question. We like to see less than 10% for a CV for factor VIII assays at the 40, 50, 60 IU per deciliter. I think we have to acknowledge that there is some variability. I think we can tolerate some variability. It's really, for me, about what would be the level that might begin to change a patient management decision, for example, the requirement for a top-up treatment and so on. So I think less than 10%, and it's highly achievable at a level of 40, 50, 60. I like to have a QC at that level. I think it's important to have QCs around the decision limit. If we had a QC at the lower end, at, let's say 5 IU per deciliter, then I think we have to be cautious about being too over optimistic in terms of percent. You can think, of course, if I get 4, I get 5, I get 6. I think this is the best the assays can often deliver, and it's an acceptable variability. But if you've got those kind of figures, when you come to calculate CVs, you're significantly above 10%. So I think we have to bear in mind the level of activity also.
Okay, thank you. Thank you for everyone. Our time is gone. If you have any questions, please, you can write us, and we will be a pleasure to send these questions for the specific speaker, and they can answer you in separated. So I would like to just ask Silmara to do an invitation for the next webinar.
Sí, gracias por su participación, gracias a todos por la participación. Estoy muy contenta con el número de personas que están ahí con nosotros. Gostaria de invitarlos al próximo webinar, que será en noviembre, que vamos a hablar de la parte de hemofilia, de investigación, de von Willebrand, la parte de cofactor de histocetin, de factor 8 para a avaliação de von Willebrand de hemofilia e também a parte de inibidores. Então, é com muito gosto, espero que han disfrutado desta sessão e claro que vamos ter ustedes com um e-mail se tem algo, alguma dúvida que não foi acá discutido, podemos então responder para ustedes por e-mail. Graças a todos por la participação.
Okay, thank you very much. And was wonderful morning, and I hope everybody enjoy it. Like waiting you guys next month for the second webinar. Okay, thank you.